Good afternoon and good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing focuses on advancing the Africa's health security and sovereignty agenda, in addition to a spotlight on the health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. And just to let everyone know that we have French translation on channel 2. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you so much, Director Margaret. Good morning, good afternoon, good evening, depending on where you are. It's my pleasure once again to take the press briefing today on behalf of our Director General, Dr. Jean Kaseya. So I'm pleased to welcome you, journalists, scientists, public health experts, who every Thursday come to engage us to know what is happening in the continent as health is concerned. And then you will see how we are going to highlight some of the challenges that we are facing due to the climate change, but also some of the solutions that some of our countries are implementing, especially on the domestic financing. So over to you, Director Margaret. Thank you. As mentioned, we will go during this press briefing to we'll highlight some of the challenge that the continent is facing, some of those challenges due to the ongoing climate change and the impact. Next slide. So before that, we will give more feedback. You remember last week we were already talking about the African Manufacturing Pre-Marketplace Forum that took place in Addis Ababa. So during this meeting, our director, which did the opening, emphasized the need to push the partnership, specifically on the local manufacturing. That's why this meeting was co-organized by Africa CDC, but also Gavi, the Global Alliance for Vaccine Alliance, to advance the local vaccine manufacturing. So it was really the opportunity to discuss, to pause, to look how far we are, but also to remind what are the expectations, what are the bold ambition, knowing that as per today, less than 1% of the vaccine used in the continent are actually produced in Africa. We are also looking that the African medicine and vaccine market actually exceeds 50 billion annually. So there is a mismatch that needs to be addressed. And to address this gap, strengthening health sovereignty requires predictable demand, strong regulation, and sustainable financing, because the industrial, the private sector will invest significantly based on the opportunity that they will find that actually exists in the market. So the goal is quite clear. 60% of Africa vaccine needs to be manufactured in the continent by 2040 and leverage on 574 health product manufacturers, including 25 vaccine producers. So we have a long way, but we are quite ambitious. And that's why following this pre-market forum, we'll have the extraordinary summit that will take place before June, the Q2 of this year in Nairobi, where the President Ruto, who is the champion for local manufacturing, will continue the conversation with practical way forward to achieve the goal that has been mentioned. Next slide. This contributes to the conversation that Africa CDC is leading on reimagining global health architecture. So in this paper that has been led by our Director General and our senior author, Dr. Gashi, highlight the way forward to ensure global health security. And what we've learned with the different crises, the different opportunity and challenge that the continents are faced is that global health system must prioritize equity and regional leadership. We've seen how the continent have been suffering for the COVID and even the early days of Mpox in terms of vaccine and medical countermeasure access. So it's required that leadership to address the inequity that we've seen. And that will ensure that Africa has a stronger voice in global health decision-making. That's the only way for our people, our population, to receive what is needed. But also emphasize that sustainable and predictable financing is essential to really move beyond the donor-driven model toward domestic resource mobilization and aligned global investment. You've all witnessed the impact of the decrease of the ODA. So now we've also appreciated as one of the key lessons on how we should adapt, adjust, and therefore change our modus of operating. But the other lesson, the third one, is the regional manufacturing, where research capacity and data equity are critical to strengthen the preparedness and reduce the dependence on external supplier. Now, saying that, there are 5 strategic priorities if we really want to reimagine and to change the global public health. The first one is to strengthen primary healthcare system as the foundation for a resilient health system. You remember the meeting that happened a few weeks in Addis was where the primary healthcare digitalization was at the key. This is one of the key priorities. The second one is to promote sustainable domestic financing aligned with national and regional health priorities. We'll come back to that later. The third one, ensure equitable access to vaccine, diagnostic, and therapeutics, supported by stronger regulatory and governance system. And then when we talk about that, we talk about the AMA was already there to provide that regulatory environment so that we can really push the agenda of medical countermeasure produced in the continent, which is the fourth one, to advance the regional manufacturing and the coordinated research to provide the evidence that are critically needed to move that process. And these include technology transfer and intellectual property dialogue. The fifth, but not the least, is to strengthen the regional institution and governance framework to support accountability, transparency, and inclusive global health leadership. So those are the 5 strategic priorities, and you will see in the next slide how this is happening in the continent. Next slide. So this is one example in Democratic Republic of Congo, this which is near historic 14.5% Abuja target for health sovereignty. And in those 2 op-ed that was published, one in Jeune Afrique, where the President Félix Tshisekedi highlighted that la RDC est sur la voie de la souveraineté sanitaire. So the DRC is on the track to the sanitary sovereignty. And the second one in DEVEX, together with the Prime Minister and also the Minister of Health of DRC, all the 2 of them supported by our Director General, to emphasize that financing is only half of sovereignty. Stewardship is the other half. So you can see how the DRC is rapidly increasing the domestic health financing. This is a good example of the new mechanism, the import levy and the mandatory insurance that are reducing donor dependence and expanding the coverage. The second one is to highlight the strong push on public financial management, which aim to cut inefficiency and ensure fund deliver real services. You remember that DRC is one of the countries that will receive the support of Africa CDC with the provision of a finance expert that will be seated together with the Ministry of Health to ensure that they actually push that agenda of public financial management. 20 other African countries will receive the same support. The fourth point to highlight is the reform that emphasizes accountability, digitization, and pool procurement to improve efficiency and equity. On the issue of digitization, you remember when we were arguing, emphasizing the research that was done in DRC, emphasizing that $800 million is wasted every year because of the ghost workers. So if all that is being digitized, then it will also have an impact on the accountability and therefore improve the efficiency and later on the equity. So all that is really relying on the Africa CDC and align with the Lusaka agenda. So the strategy really which aims to build a self-resilient health system with a lower household burden, because we know in most of our country, the out-of-pocket is quite expensive, representing in some countries 70% on the health expenditure. By moving forward those different opportunities as we are seeing in DRC, this will relieve the population and therefore they can use their money to other things like education of their children and families. Next slide. Now, this week, we are in Madagascar with the African Union Committee, specifically the Health and Humanitarian Affairs and Social Development Department. This is the joint mission emphasizing the need to coordinate within the African Union when we have that kind of event as it's affecting currently Madagascar. As you may know, Madagascar has been hit by two cyclones, Fitia and Gezani. Gezani was the latest one, and the two of them has resulted in 73 deaths, 681,000 people affected, 60,000 displaced, and over 122,000 houses that has been damaged. So the visit actually starts with the engagement at the highest level with the Ministry of Foreign Affairs and showing the solidarity of the African Union toward the government of Madagascar. The support is both financial, technical, with the $200,000 that has been handed over at the Ministry of Internal Affairs to strengthen the effort of the cyclone. As you can see in one of this picture, how the country are being significantly affected, especially on the site of Tamatave, where the colleagues are currently doing the assessment on what are the mid and long-term needs beyond those immediate. But also, as you know, Madagascar, and you will see later on, is quite affected by the Mpox pandemic, and therefore we have handed over the Emergency Operating Center for a value of $200,000, which include the equipment, the material, but also quite important, the capacity building of 4 national staff on the incident management system. So that is really the structure that is supporting them as we do speak now to manage to control the different outbreaks, including Mpox, but also to prevent other that may occur as an effect of the cyclone. Next slide. So going back to our public health event, you can see that the cholera continued to grow in the continental to lead actually in terms of the number of confirmed cases, but also number of deaths, 484 since the beginning of this year, followed by the measles with 343 deaths, and then Mpox, Lassa fever, and diphtheria. Next slide. Talking about Mpox, as you've seen in the first slide, we are keep on moving between the transition of Mpox, between the emergency to the control at the local level. And this is a process. The process includes the transition roadmap, which will be launched when we'll be meeting the member state during what we call the after action review, early next month of April. That will allow the country to have all the tools, but also the partners on how they will be dealing with Mpox at the national level. But as we do speak now, and as you will see in the next slide, Madagascar, DRC, Liberia, Kenya, and Burundi contributed to 84% of the case in the last 6 weeks. So the transition routine, as I mentioned, will be discussed during the after action review. Next slide. In Comoros, the situation is as follows. 28 cases have been confirmed out of the 64 suspected cases. So the good news is that the number of cases has been reducing for the last 3 weeks, as you can see in the graph. But there is an important but. When you look at the test positivity rate of 100%, these highlight that all the positive are the ones who actually went to the health facility and were diagnosed, which means that there is an important number of suspected case may be confirmed that could still be in the community, emphasizing the need of the active surveillance, which is one of the discussions that we are having with the country as we do speak now. In the meantime, the preparation of the shipment of 10,000 doses of vaccine is being made, and then we'll soon have the time when it will arrive. So at this point, it's critical for us to support a country on implementing a strategy that will allow them to focus on the hotspot as we see with Madagascar, so that the right population will be identified in the community and therefore will be receiving the vaccine as a way of protection. Next slide. In Madagascar, where we are this week, you can see that the number of confirmed cases has been slightly reducing, moving from 105 to 82. In terms of death as well, this week there is no death. The only death that has occurred was a young girl, and that was really traumatic in the country because a girl of 3 years old. And the challenge was that before reaching to the health facility, she was brought to different traditional healers and so on. And that emphasized a strong conversation that we have with the country on the need to strengthen the active surveillance and also the integration of the civil society. So during the discussion that we had with the country, we were quite pleased to see first how the integration of all those CSO is happening. Those are the key people who engage the key population, people living with HIV, the sex workers, and so on, to ensure that one, they get the right information, two, they are sensitized, and therefore they will be the main target of the vaccination that has already started. Talking about the vaccination, they started with the vaccination of 524 health workers, which has happened since last week. And those ones are happening in different health facilities. So when we were discussing with them, as you can see in the picture, they were highlighting that they really want to protect themselves. One, because they are in the front line, but also to send the good message to the community. Once discussing with the colleagues who are showing a great motivation on fighting this outbreak, we agree that at this point of time, it's critical to focus on the 5 districts that represent 74% of the confirmed case, so that the integration of the active surveillance, the risk communication and community engagement, the vaccination, the IPC can happen, because this is how, through the integration, we manage to be more efficient, as we've seen in many other countries, in Sierra Leone, in Liberia, Uganda, and other countries. So this, based on those lessons learned, the strategy will be changed in the country to have that intensification that should be started next week by the training of community healthcare workers that will be deployed in the country. Next slide. In Cameroon, the situation is being monitored closely. We've been having last week 0 case, and this week we have 2. The peak was 3 cases per week. That was week 46 in 2025. But now, when we look at the recent, we have 1 case every week, highlighting an ongoing widespread transmission in urban area like Daido, which is quite a popular quarter in Douala. And that emphasizes the sexual transmission that is happening. Now, in terms of response beyond the survey that is happening, Cameroon will also soon receive 10,000 doses of vaccine and will also implement that integrated strategy where the surveillance will go along with the vaccination. Next slide. In Kenya, where we have reached the 1,000 confirmed case out of the 2,734 suspected case, 19 deaths have been confirmed, which gives a case fatality ratio of 1.8%. Now, as you can see, for the last six weeks, we have been seeing an increase in the number of cases. The test positivity rate is quite high, highlighting the challenges that the country is currently facing in terms of active surveillance, especially in Mombasa, which still accounts for the majority of the number of total confirmed cases, around 40%. And one of the main challenges that the country is also facing currently is, though the vaccines are available, the mobilization of the fund, the operational fund to run that vaccination is being a challenge. So therefore, we are really finding ways, but also engaging the different partners at the national level to find ways, like it's happening in Madagascar, where the partner at the national level have managed to raise the fund to support the country for this vaccination effort. Because when you see that 71% of the confirmed cases were managed through home care, it means that the burden of the disease remain with the community. Therefore, we need really to strengthen the active surveillance and to ensure that the funds are available so that the vaccination can happen at the same time of the surveillance and the community engagement. Next slide. In terms of vaccine, as mentioned, we've reached the 5 million doses that has been delivered in 7 countries, with 15 countries that have been vaccinated, almost 2 million of MVABN and 3 million that was sent to DRC bilaterally with the support with the Japanese government. So now in terms of administration, we are almost reaching the 3 million people who have received the vaccine. 1.4 million who have received the MVABN and 1.59 million have received the SC16 that is specifically in DRC. Now, as mentioned, the different bodies that are supporting the vaccine allocation have approved the 10,000 doses of vaccine that will go to Cameroon and the 10,000 that will go to Comoros. And as we do speak now, the country have approved, has accepted the offer, and therefore all the logistics is now happening so that the vaccine could reach the country as soon as possible and they can implement the vaccination as it is in the plan. Next slide. Now, going to cholera, we can see as we do speak from the beginning of this year, we have 14 member states that have been reporting cholera for a total number of cases of 23,776. And we can tell that 59% of the global cholera cases are in Africa and 99% of the global deaths are also in the continent, with a case fatality ratio of 2.03%, considering the 480 deaths out of the 23,000. This is pretty high. You remember that what we are trying to achieve is to reduce it to 1% at least. So when we look at the country affected and we go to them, we have DRC, Mozambique that contribute to 84% of the total case, while they contribute to 92% of the death in 2026. Sudan has declared the end of the outbreak, which we've mentioned, and we now follow up how they can also implement the after-action review to see what are the lessons learned and how this can lead now to the cholera elimination plan by 2030. The new outbreak in 2026 has been in Rwanda and in Zimbabwe. Next slide. Now, when we look, we compare the evolution in the last 6 weeks in the different country, we can see the country where there is an increase. The first one is Angola, and then we'll come to that. We'll see that Angola, we know, have already been having 2 waves of cholera, so it's critical to monitor the situation there, but also Zimbabwe and Zambia, where we see an increased number of cases. In terms of countries where we see some decline, DRC is 1% decline, showing that it's pretty much stable, with actually the highest number of cases and deaths that has been reported in the continent, followed by Mozambique, South Sudan, and Burundi. Next slide. Specifically in the Southern Africa region, as the 15th of March, we can see the weight of Angola. This is 2025, 2026, with the highest number of cases, but also the highest number of deaths. But now, when we go to Zimbabwe, which is currently the country with the highest case fatality ratio with 3.2%, 24 deaths out of 758. So this is also highlighting how the support has to be critical in terms of case management so that we can, one, stop the spread of the disease, which can happen with the measure that we know, the surveillance, the vaccination, and so on, but also more critically on the case management to ensure that we have a lowest number of how people will die because of that disease. Next slide. In Angola, as mentioned, Angola has been typical because we are highlighting the fact that the country has already seen 2 waves of the cholera outbreak. Now, with those new cases, it's re-emphasizing the fact that stopping an outbreak using vaccine and all other medical measure, it's only part of the solution. And the critical challenge remains the access to water. As you see, we keep on highlighting that roughly 54% of the population lack access to safe drinking water, and only about 55% have adequate sanitation. So although we can manage to stop a wave, it will come back until we have a proper access. And to have that proper access, we need also to increase the dose of OCV vaccine so that we can have those preventive vaccination. The advantage of that preventive vaccination strategy is that giving two doses, we increase the duration of the protection, which can go up to 5 years. That will give time to a country like Angola to ensure that in those cholera endemic settings, they can invest and accelerate the access to water. And that remind us, if needed, that the response to cholera, as we were discussing this morning with the colleague of UNICEF and WHO, need a critical investment and in commitment of ministry other than the Ministry of Health. More specifically, the ministry in charge of water, the Ministry of Decentralization, and of course, the Ministry of Finance, so that that can be prioritized. Next slide. In DRC, I mentioned a slight stabilization, but as you can see, that the country is still contributing for the highest. So now what is happening as we do speak now, the vaccination, there are two types of vaccination that will happen. The one I mentioned, the reactive vaccination to stop the outbreak, which will be used 2 million doses targeting the Okatanga, Lululaba, and the Tanganyika, while the preventive vaccination with the 2 doses per population will happen, including in Malaka prison, in Kinshasa, where some case has been found, but also in the Lomami. So the hotspot are also those where the reactive vaccination will happen. Next slide. Mozambique is one of the countries that we highlight the issue of cholera, and then you will see in the next slide how it's linked with the issue of climate change. So in terms of cholera specifically, so far we have seen 125 deaths out of 11,000 cases with a case fatality ratio of 1.1%. As we do speak in terms of strategy, specifically the vaccination, the ongoing vaccination preventive target 1.7 million in high-risk urban. Those are really the hotspot, while the reactive is also looking at Tete and Nampula, which might be exposed because of the location close to the endemic setting. The challenge is how to accelerate with limited fund the availability of treatment center and specifically the rehydration point that are critical. Some have been established, and now the need is to accelerate, and that will be part of the support that is planned by IMST and the different partners. Next slide. As I was mentioning, still in Mozambique, the flooding that has been happening from January and February, they are affected over 700,000 people. And this is also the continuation of the tropical cyclone feature, which remember have also touched Madagascar. So 370,000 people have been displaced, leading also to 270 deaths. And this flooding, the impact first on the waterborne disease, which includes cholera as we did speak, but also other vector-borne disease, including malaria, dengue, because then it provides the breeding site where the mosquito can have the eggs. The other challenge that is happening is the food shortage and, of course, the malnutrition. Next slide. Now we'll end with the landslide that happened in Ethiopia in March 2026. That has been reported on the 11th of March with heavy rainfall that made the landfall and flash flood in the country. So 125 deaths have been reported, which happened in Gamo zone in the South Ethiopia region, as you can see down in the map. So far 10,000 people have been displaced, the majority of them being female. Schools have been affected, only one, but the damage has been mainly in the infrastructure, as you can see in the picture. So the intervention has been have been happening, and then we commend the leadership of the country in terms of searching and rescue operations that are still ongoing, the disaster and command post that has been established. So the potential public health impact has been the population displacement, which also, if nothing is done, but that's not the case here, could have led to the spread of disease that we've been mentioning before. And the food shortage and malnutrition is also one of the impact that could be expected due to that kind of emergency. Next slide. So we've seen the joint mission that has happened in Madagascar to send a message of solidarity for the government of Madagascar, which has been affected on one side by the cyclone, but also by mpox, emphasizing the role and the diversity of the organ at the African Union, who have the capacity to go and address in a holistic manner the challenge that our member states are facing. Africa CDC is leading the global health reform architecture agenda, which include the local manufacturing agenda, and also moving towards at least 60% of our Africa vaccine that need to be manufactured in the continent by 2040. The other pillar, which is also critical, which is the domestic financing, has highlighted in those two op-ed how Democratic Republic of Congo is really moving forward, getting the Abuja Declaration, we've reached in the 14.2% of the GDP invested into health. The heavy rain triggered landslide and flash flood in southern Ethiopia, killing the 125 people that we've just mentioned, while the severe flooding in Mozambique affected a large number of population and also contributing in a way to the spread of cholera. So as mpox is concerned, we have a country, Comoros, Cameroon, who will soon receive the vaccine, while Madagascar, with the fractional dose, will with 30,000 doses, will be able to reach between 90 to 120 people that will be receiving the vaccine. And talking about those vaccines, it has already reached 3 million people that have been vaccinated in 15 countries, though the uptake remains uneven depending on the country. So as cholera is concerned, major challenge in our continent that represent 99% of all reported cases. We've seen the increased transmission in Southern African member states, but also the sustained transmission in DRC. And when we've seen how the flooding, the climate change can also affect the cholera spread in different countries. So with that, I will pause and I will be happy with all my colleagues to take the question of our dear journalist. Over to you, Director Margaret.
Thank you very much, Prof. Let's take the first two questions. We have one from Inez of APM Market Access. The question is, does Africa CDC have any concern that bilateral agreements such as the reported draft Zambia-US Health MOU could undermine African countries' policy, autonomy, data sovereignty, or alignment with continent-led health priorities? That is the first question. We have another one here on a cholera outbreak from Israel. The question is, faced with the cholera outbreak, we often find ourselves unable to respond promptly due to a lack of resources. Are there any other procedures that Africa CDC is using to stop this epidemic? I'll hand over the floor back to you, Prof.
Okay, thank you. Thank you so much, Ines, and the other colleagues for the great question. The first one, whether are we concerned about the bilateral agreement which the US government is currently having with different member states, and you highlighted Zambia and Zimbabwe who have not signed, while many others have signed. And actually, last week, some other countries were already on the monitoring of how this will be implemented. Worry? No, we are not worried. And remember what our DJ was highlighting, that Africa CDC is there to support the member state. So those who have already signed, we will be supporting them on the implementation, wherever there is a need to strengthen the implementation to ensure accountability, efficiency, and transparency. Will be there to do that. For the countries now that have not signed, it's also part of the Africa CDC to have that conversation and understand what has been the barrier, the challenge, so that we can also support the member state. On the second question on cholera, you are right. It's sometimes a challenge for the member state to receive the fund that they need to react to those outbreaks. But also, cholera have not been having the attention that was needed. That's why we together with our aid champion, the president of Zambia, His Excellency Ichilema, to ensure that we have that plan. And the plan used two instruments, the first one being the IMST, which is pushing the response, and the other one is the task force, which is more on the preparedness. But now, specifically to your question, in terms of funding, we've mentioned the African Epidemic Fund that will mobilize some funds so that our emergency rapid readiness system could be implemented. What does this mean? It means that we will have the fund available to deploy within 48 hours. Teams to go in countries with what we need in terms of medical countermeasure, whether we are talking about live diagnostic, whether we are talking about what is needed for the community risk communication and community engagement, whether we are talking about the PPE for the IPC, all those needs will be stocked so that within 48 hours we can deploy a team of 6 to 10 people who will go and support the member state to really control the outbreak at the source. Then based on how it's evolved, there might be other teams. So that we believe will significantly reduce the time for deployment, but also limit the expansion of the different outbreaks. So that is where we are moving forward. And then we appreciate that country like DRC with the domestic financing, we also increase their contribution to the African Epidemic Fund. Over to you, Margaret. Dr. Margaret, can you hear me?
Michael, yes, Prof, can you hear me?
Yes, now I can hear you.
I think I'm frozen. Great. We're moving back to the floor for the next question. We have Michael Guarisa from Health Times in Zimbabwe. Just a minute. Hello, I'm back online. Can you hear me?
Yes, we can hear you now, Director.
Where's the list? All right, let's take the next question. I have don't see Michael. All right, I have Rachel Abuja from the Nigerian News Agency. Rachel, if you can hear me, you have the floor.
Good afternoon, Margaret and Prof. Thank you for the opportunity again. Prof, my question is this: with the goal of producing 60% of Africans' vaccines locally by 2040, what specific mechanisms are being put in place to ensure sustainable financing, technology transfer, and regulatory alignment across the continent? And how will private sector engagement be how will the private sector come in to say? That's one question. And on MPOS, with MPOS case, in hotspots like Madagascar and Kenya, how is the African CDC ensuring that community engagement, civil society participation, and frontline health workers training are effectively coordinated to minimize both vaccination uptake and early detection? Thank you, and over.
Back to you, Prof.
Okay, thank you. So I will let the question on Mpox to Dr. Mercy, who will emphasize the experience that we've just seen of the integration of the CSO in Madagascar. So Rachel, your first question on the goal of 60% of the vaccine being manufactured in the continent, and then you are highlighting how this can be sustained. The first one on the regulatory side, we have the African Manufacturing Agency, which role will really be to ensure that we have the regulatory structure. And that links also to how the private sector is engaged, because one challenge that the manufacturer has been highlighted is when they will have one product, they will need to make it approved in the 55 member states. So now the mechanism where we are moving forward is to ensure that once it's approved at the continental level, then it can be approved in many countries. That will be an incentive for them. So the second incentive in terms of tech transfer is, what is the demand? So the work that we are doing is, one, on the side of prioritization of the disease, to see what are the key diseases that the continent will be facing. And that provides an estimation of what will be the demand if we go to the issue of Mpox, for example, when we are looking at what we call herd immunity, mean that we'll need to protect the population in endemic countries, DRC, Cameroon, Central African Republic. We can already talk about millions of people who will need to be vaccinated. And if you recall in one of our briefing a while ago, Bavarian Nordic highlighted that for the tech transfer to happen, they need to have at least a demand of 3 to 4 million. So looking at how we can present the demand, it provides an incentive. And that conversation with the manufacturer will be led by our local manufacturing division within Africa CDC, which also was the one that has the pre-market meeting that I mentioned, to engage and bring together the manufacturer, the regulator, and the member state to ensure that that conversation happen, so that we have a clear demand, we have an incentive for the tech transfer, and then we also push the domestic financing. That's the money that we sustain the buying of those vaccines. But remember also, when we say that 1% of the vaccine are being produced in the continent, the 99% are being bought. So which means the resource to buy the vaccine might be there. We also push the donors to ensure that instead of buying the vaccine that are coming from out, they will also have the incentive to support the vaccine that are locally produced. Over to you, Dr. Mercy, for the question on the integration of the CSO for Mpox fight.
Thank you, Prof. Good afternoon, journalists, and thank you for that very important question. So as you rightly have mentioned, the target during response is mainly focusing around the hotspots. And as epidemiologists supporting countries during this acute phase of the response, one of the very critical steps that must be taken is really to support countries to understand the hotspots, and not just at very district level, but really going down to the local level to understand where we're having the cases and where the transmission is really currently active. If in Madagascar, where we currently are supporting our response, we have supported the country to come up with some major hotspots, looking at the last 6 weeks of the outbreak. And so we've really gone down to understand where the Fukutani, which are really the lowest levels of the healthcare system, the most affected Fukutani, and we've been able to have that. And one of the strategies that we're putting in place is to ensure that we bring all the stakeholders to the table, especially those that have been actively involved in community health worker training, just to ensure that there is some level of coordination, because we've seen that as a serious gap in several countries during response. And the second thing that Africa CDC is also championing is ensuring that we move from the vertical approach in terms of community healthcare worker training to really looking at the polyvalent approach where community health workers actually trained on multiple public health threats. In the case of Madagascar, when we are looking at Mpox, mind you, Madagascar is not only being affected by Mpox at the moment, they also have chikungunya outbreaks currently being reported and other threats. So it's really important that we really don't look at it from a very myopic lens, but really ensure that we have an integrated approach in terms of building the capacity, not only at the disease level where we're integrating, but also at the pillar level. As you know, most community health workers that are being targeted for risk communication and community engagement are the same community health workers that are also being targeted by the surveillance folks, as well as the community IPC folks. You know, they all go down with different training modules to build their capacity to be able to detect, to be able to engage the communities. But this happened at different times. So what we are also supporting the country to do is to bring these different pillars together, harmonize the training material so that we go they are able to use just a single convening for these community workers to be able to build their capacity and train them. Then the third phase, of course, which looks into the bigger vision, is ensuring that even after this outbreak response phases out, these community healthcare workers are being integrated into the healthcare system. And this really requires high-level advocacy, a political will, leadership to be able to get this done. And that is the continent we want to see, where these community healthcare workers are not just being ad hocly recruited, but again, they are actually part and parcel of the healthcare system, and they are motivated as such. Then lastly, I think one of the challenges that we've also realized is that the community health workers do exist in all the countries. There's no country that would say that they don't have community health workers. But the challenge for the most part is actually getting them motivated and sustaining them. And while during outbreaks, we are able to get them facilitated, like I mentioned, the long-term sustainability approach is to get them integrated. And for some of these vertical programs that do exist, that have already been motivating community health workers, like polio program, we can also leverage those different programs to be able to ensure that they're able to sustain community health workers to also detect other public health threats. I'll leave it here. Thank you so much, Prof.
Yes, thank you, Mercy. And just to add that those community workers are also working hand in hand with the civil society organization. So in Madagascar, as she mentioned, we listen to up to 10 CSO, religious, those taking care of people living with HIV, but also those who have been supporting the Association of Sexual Professionals. And those ones are quite critical. They've show us some very important data. Well, more than 20,000 people have been sensitized. They've also been able to refer more than 1,000 of the suspected case, but also highlighting some of the confirmed case that came out from the engagement. So now that they're moving to the vaccination, they will be the one to talk to their peer to ensure that they have the right information, but also that the vaccination happen in the place where they are comfortable, so that in one hand, we do our public health intervention, but also in the second hand, we avoid stigmatization. Over to you, Dr. Margaret.
Thank you very much, Prof. Let's take the next question. We have Esther Nakazi, is a health and science journalist from Uganda. Esther, you have the floor.
Thank you, Prof, and thank you, Margaret. Prof, so the SAGE just approved the use of COVID-19 vaccines. My question is, do we know if we have these available in our respective African countries? Because the recommendation seems like we have to use more of these vaccines. And then secondly, you have continuously talked about operational funds that need to be available from countries, but some countries do not have these operational funds to use the vaccines like mpox vaccines. So what exactly happens? Do you first ask the country if it has the operational funds to disperse the vaccines, or you just give the vaccines before you get that understanding? And how does that work really if they can't get the funding to take the vaccines to the in the arms of the people? And lastly, you say the DRC has now almost gotten to 15% funding domestically for complying with the Abuja declaration. Does that negate the fact that they will okay, maybe you don't speak for the government, but does that play into how much they can accept to get funding from the US under the new system that they are using to get funding from countries? Thank you, and over to you.
Yes, thank you so much, Esther, for always bringing some very, very good question. So the question on the SAGE and the Operation Fund, I will let Dr. Ibeneme, our vaccine pillar lead, answer them. Now, on the question of the DRC, so next week we'll have the pleasure to have our Director General, Dr. Jean Kaseya, together with the Minister of Health of DRC. They will come to go deep dive on what has been done, what is the plan. So definitely all the questions that you are having, that you are asking yourself and many others will be answered next week. So maybe I will hand over to Charles on the question around the vaccination.
Yes, thank you so much, Prof. I hope you can see me. Thank you.
Yes.
Yeah, so, and thank you so much for the question. So, yes, there was a SAGE meeting from 9 to 12 just yesterday. So we are still, there are key recommendations from this meeting actually, but on our side, we are still trying to take a better glance at the key recommendations and outcome of this meeting. Hopefully we'll be able to give a statement on the stand, probably by the next press briefing. However, around the availability of COVID-19 vaccines, we do know that as the risk perception has reduced on the continent so far, most countries currently do not have COVID-19 vaccines. But you would recall that one of the priority for Africa CDC through the Saving Lives and Livelihood Project was to move forward, in terms of integration of COVID-19 vaccines into routine services. So I think this recommendation from SAGE would, in one way, strengthen the key priorities of that particular project. But like I said, we are still trying to explore to see what are the key gains from this current SAGE meeting, and we will definitely follow up to see how to best support countries, especially those who currently do not have vaccines, to see if there is a way to support them with having these vaccines. And for those who do have vaccines, to see how to best explore its utilization. Thank you, and back to you, Prof.
Yes, I can just add that the question on the Operation Fund, there are different examples. You have a country like Uganda, where you are. Uganda has, I think it's this week, correct me, Charles, they've used all the doses of vaccine that they've received, which is more than 360,000 doses of vaccine. And the fund that they initially received was for the first 100,000 doses. So highlighting that Uganda has managed to find within the country the money to support that. As Dr. Messi mentioned, we are in Madagascar, where the fractional dose is happening. Fractional dose mean that they use one vial for 4 to 5 people, and they did not also receive the operational fund. So what they did, they look at the different partners, and it's the WHO who are supported to over 90,000 to ensure that the vaccination can start. So different countries will have different models. In DRC, for example, at some point, the vaccination in some district was supported by the private sector, where there were some mining industry who actually support the government because they want to protect the population. So it's critical to think out of the box in those countries, but we appreciate that it's quite difficult. It is difficult, and we do the concern when it happened is that the vaccine, which are quite expensive, could expire. So in terms of process, we start with the challenge. The country needs vaccine, vaccine available, we support the vaccine to receive them. In the meantime, or in parallel, we support the country to find options within the country to actually find the resources to vaccinate the population. Over.
Let's take the last question. We have Michael Barisa from Health Times in Zimbabwe. Michael, you have the floor.
Thank you so much, Prof, for your time.
Michael?
Yes, can you hear me?
Go ahead.
Yes.
Okay, thank you so much. So my question is on cholera in Zimbabwe. That's where I'm from. The Africa CDC has been reporting the cholera situation consistently. Unfortunately, the government this side has not said a word since the Africa CDC announced around 6 February that there was a cholera outbreak in Zimbabwe. So people are actually in the dark. Maybe could you just give a brief breakdown of the number of cases that we have right now and probably the number of deaths, since you indicated that Zimbabwe has the highest case fatality rate in the region. And probably what message would you want to give to the government of Zimbabwe regarding communicating the cholera situation? Because as it stands, everybody's in the dark, but cholera is spreading and new cases are still being reported. Thank you so much.
Back to you, Prof.
Okay, so I will let Dr. Messi handle the question of the number. But in terms of communication, one of the reasons why we really push cholera at the highest political level is because it has not been received enough attention. So that's why we have our champions, the AU champion for cholera, the president of Zambia, who has instructed us to build the Continental Cholera Task Force. And one of the missions that he will have as part of that is to facilitate in countries the establishment or the elevation of the National Cholera Task Force, so that in Zimbabwe, where you are, this task force will be strengthened at the highest level, where the president will be leading together with the Ministry of Health, because it's an health issue, but also the Minister of Finance and WASH, so that they can respond not only to the outbreak, but also to invest in infrastructure to ensure that it does not happen again. So now, in terms of the actual data, Dr. Messi will be able to provide some hint. Dr. Messi?
Thank you so much, Prof. And just to also reiterate that we do respect the government stance, and this is not in any way saying the government is not reporting. The government has been reported. I'm sure maybe you just need to get to the right person within the Ministry of Health. They'll definitely give you the numbers. And so far, we have received reports of 13 confirmed cases and 23 suspected cases, and 2 deaths that have been reported since the beginning of the outbreak. But I would also kindly say, I don't think the government is hiding anything. Maybe you are not just talking to the right people within the Ministry of Health, because the data is available. Over.
Thank you very much, Dr. Masi and Prof. With that, we have come to the end of the briefing this week. I'll hand over the floor back to you for your closing remarks.
Thank you so much, Director Margaret. Thank you all the colleagues who have been supporting us. But thank you so much once again to the journalists for being there, for the accountability, the transparency, and ensuring that we provide you the right information, and also to all the public experts who are listening to us. And as mentioned, the good example of DSC, which is moving forward toward achieving the commitment of the Abuja Declaration, will be discussed in depth next week. We have the Director General, Dr. Jean Kaseya, and the Minister of Health, Dr. Kamba. So on the side of Mpox, cholera, we really appreciate the effort of our colleagues, of the member state, really fighting different outbreaks at the same time to ensure that our population is safe. With that, we say thank you, and will be with us next week at the same time.